Hello, everybody. I'm Dr. Ben Kitchens. I think they introduced me a little earlier. Hope you're having a wonderful morning. Sounds like there's been some good talks. As they mentioned, I'm an oncologist down here with Texas Oncology at Baylor in Dallas. I was a hospitalist for 3 years, so I am one of you at heart. Did that in between residency and fellowship. But we're going to be talking about kind of the intersection of what we do as oncologists and the drugs that we give, and how we can work together to take care of those folks that are experiencing toxicities related to these things. So our learning objectives today, we're going to be looking at treatment-related adverse events, specifically ones that are grade 3 or more that are going to put people in the hospital, specifically related to our newer therapies in the oncology world, those being immune checkpoint inhibitors, also antibody-drug conjugates, and we'll be getting into detail about cellular therapies, which are becoming much more ubiquitous in our armamentarium. And then we'll also be talking about how we can put together an initial diagnostic workup when we see these patients, and how we can address treatment and management of these adverse events. So before we get started, as is normal with these things, we'll be doing some pre-test questions. I'm going to go ahead and read these off for you, and you guys can answer. So Sam is a 65-year-old man. He comes in with a fever of 38.3 centigrade. He's neutropenic with an ANC of 150, and his Multinational Association for Supportive Care in Cancer, or MASC score, is 20. He has a medical history of gastric cancer and is currently receiving trastuzumab deruxtecan, aka Enhertu, and the GFR is 80. What would be our initial empiric treatment for this patient? Go ahead and select between ciprofloxacin, cefepime, or Zosyn Q6. Right, looks like we got a pretty even spread. Looks like the majority of us were choosing cefepime. Don't recall if I'm supposed to, I think I go over all these answers at the end. Yeah, because this is a pre-test. So we're going to go into the next question. I liked that music. I wish I had that while I was taking my boards. Would have made it a more pleasant experience. So Tara is a 60-year-old woman. She also started trastuzumab deruxtecan, or Enhertu, and she presented to the emergency room. Tara, yeah. She presented to the emergency room with fatigue, shortness of breath, as well as dyspnea, shortness of breath and dyspnea. She was diagnosed with grade 4 pneumonitis. What would be the appropriate management for this patient? Grade 4 pneumonitis. All right, more definitive answers here. Looks like we have a strong showing for promptly initiating systemic steroids and gradually tapering those and stopping the drug. All right, we can go on to the next question. Which of the following medications should be considered for prophylaxis of a high-risk patient that could potentially experience tumor lysis syndrome, or TLS? Allopurinol or aspiricase, pegloticase, or febuxostat? I like the even spread of answers. It means we have a lot to learn and talk about. We are going to proceed with our slides here. So again, we're going to be talking about new oncology therapies and the adverse events that we can encounter, particularly in the inpatient setting. Probably no surprise to all of you that we have a lot of very new therapies in the oncology world. Gone are the days of us only having available to us cytotoxic chemotherapy. Of course, chemotherapy still holds a very important role in our armamentarium for treating cancer, but we have a host of new therapies currently available and continuing to come down the pipe at a constant rate. And for that reason, it's very important for all of us taking care of these patients to be aware of them to some extent, especially when it comes to the kind of things that can put them in the hospital related to our therapies. So we're going to start with probably the ones we're all most familiar with. Back when I was in medical school, people were just starting to talk about these things, and that would be the immune checkpoint inhibitors. Just to kind of put it in perspective, the very first checkpoint inhibitor was approved back in 2011. That was ipilimumab, single agent for melanoma. Since then, there has just been an explosion of trials and subsequent approvals for immune checkpoint inhibitors in myriad tumor types, from the hematologic world to the solid tumor world. It's hard to keep up with, but there are so many Keynote and Checkmate and trials out there always coming down the pipe. It's important to be aware that these drugs can cause a lot of issues because you are going to see more and more people on them. So just a bird's eye view here, the most common would be the PD-1 or PD-L1 inhibitors. I don't think it's important that hospitalists really get down to the nitty-gritty on which ones are inhibiting PD-1 and which ones are inhibiting PD-L1, because for the most part, they're going to have the same toxicity profile. But suffice it to say, the PD-L1 is going to be what is expressed on the tumor, and the PD-1 is expressed on the T cell, our immune cell. And essentially, the PD-1 is a receptor on the T cell that normally is present under physiologic conditions to keep our immune system from becoming hyperactive. And the body is able to interact with these PD-1 receptors to tamp down the immune system. It is a normal function of our normal homeostasis of our immune system. And of course, tumor cells, as they are wont to do, develop the ability to outsmart the immune system. They in turn express PD-L1, and that in turn interacts with PD-1 and tampers the immune system and prevents it from being able to do its job, which is to surveil for these cancers and tamp them down. Long story short, as you can see here, tumor cell death is averted when the tumor cells are able to blunt that immune response, and the whole goal of inhibiting PD-L1 or PD-1 with a drug is to prevent the cancer from doing so. So we have our very familiar PD-1 inhibitors, pembrolizumab or Keytruda, nivolumab or Opdivo. We also have some cemiplimab, which is starting to come on the scene with some head and neck cancers, but not nearly as common as Pembro and Nivo. Then your PD-1 inhibitors, atezolizumab, you have avelumab, durvalumab. Moving on to CTLA-4, as I mentioned, this actually, we always hear about PD-1 and PD-L1, but CTLA-4 was actually the first approval back in 2011 for melanoma. And without getting into the nitty-gritty of the entire immune system physiology, CTLA-4 essentially is described as a molecule that's higher up in the pathway. Essentially, you can think of it as the PD-1, PD-L1 axis is actually occurring in the tumor microenvironment where the T cells are interacting with the actual tumors. And CTLA-4 is happening higher up and oftentimes away from the actual milieu of the tumor microenvironment. But anyway, with CTLA-4, it's binding with B7 on the antigen-presenting cell. And again, it's the same idea. You inhibit that, and you prevent the immune system from attacking the cancer cell. And we have the most common here, ipilimumab, but there are also other ones such as tremelimumab, but they're coming down the pipe. And then finally, LAG-3 is another common, well, I say common, if you're reading the immunotherapy literature all the time, it's common. You're not going to see it a whole lot yet, but LAG-3 is a lymphocyte activating gene 3 protein inhibitor. Relatlimab is the big one coming down the pipe at the moment. Again, you look at all these diagrams with all these fancy things on here, they're all doing the exact same thing, which essentially is tamping down the immune system, preventing the body's ability from controlling the cancer, and in turn causing the cancer to do its job, which is to grow. And these drugs are trying to turn that around. Next slide here, looking at different classes of drugs. CAR T, we all hear about it. Chimeric antigen receptor T cells. This is exciting stuff. Again, we talk about an explosion of immune therapy over the last 10 years. CAR T over the last 3 years has really been a very exciting thing to watch. Just to describe this in a nutshell, these are T cells that are taken from the patient's body. We leukapheresis them out. And the way I describe it to patients is we're taking their T cells in an effort to train them, or more appropriately engineer them to more appropriately and more targeted fashion attack the tumor. So the most important thing to keep in mind for even determining if a CAR T cell is going to work is if you have an appropriate target on that tumor. The most common ones, we look over here, T-cell, axicell, lysocell. Those are for diffuse large B-cell lymphoma. They all target CD19, which is ubiquitously expressed on the lymphoma cells. Other ones here towards the bottom, ide-cel, cilta-cel, those target BCMA, which is on multiple myeloma cells. And again, these approvals are happening at a rapid pace. The diffuse large B-cell lymphoma approvals were back 2018, 2019. We're just now getting the myeloma approvals. And I guarantee you're going to see more and more of these patients. When these first came on the scene, we were looking at them in later lines of therapy, third, fourth line. Then they start getting approved in second line. And now they're starting to study them in first line. And also myeloma, all these folks used to all go straight to transplant. Now transplant is they're starting to talk about pushing that further away and supplanting transplant with CAR T. So long story short, CAR T is here. You're going to see it. And yeah. And again, just to kind of look at what these things look like, the money is really in these single chain variable fragments up here, the green and purple items. These are on the extracellular portion of the construct, and those are the things that are actually bioengineered to target the antigens on the tumors. And then in there you have these intracellular components, specifically CD3, and they also have some other components that help potentiate that response for cytokine release and killing of the tumor. Moving on. Bispecific T-cell engagers with the very cool name BiTE. This is actually a subtype of a bispecific antibody. Basically, a bispecific antibody, just think of it as an antibody that can attach to two different antigens. And you have different kinds. This very specific one is with regards to being able to attach to two different antigens on two different types of cells. The way I describe it to folks is you're trying to bring the tumor in closer contact with the immune cell, in this case, an effector T cell, to provide for optimal tumor killing. And you can see here that the BiTE molecule, just the purple and the yellow, and the yellow is contacting the cancer cell, and the purple is contacting the T cell. And the vast majority of the BiTEs that we have are contacting CD3, which is expressed on T cells, and then they're going to contact a certain marker that's specific to that type of cancer. The most common example would be a drug called Blincyto or blincytobine, which we give in ALL, and that's targeting CD19 expressed on the cancerous lymphocytes. On antibody drug conjugates, again, we're seeing lots and lots more of them. You've probably seen these at some point. I kind of describe it to patients as a smart bomb. If chemotherapy is a sledgehammer, the idea is that these are going to be more of a scalpel. Doesn't always work out that way as much as we would hope. But the general concept is that you have an antibody, again, directed towards an antigen that is specifically expressed on a tumor cell. And that antibody is attached to a drug. And if you look at all these things, essentially they are conventional chemotherapies. Azogomycin, vedotin, pacidotox, mafidotin, these are all chemotherapies, microtubule inhibitors, et cetera, that work the way our normal cytotoxic chemos work, but they are attached to this antibody, allowing for more targeted treatment. You know, the hope with these drugs is that if you're delivering the chemotherapy component specifically to the tumor cell, you're going to have less toxicity. To some extent, that's true, but as we're going to see as we move forward, that is clearly not the case across the board. It would be nice if it was. By no means do you guys have to know the or memorize the specifics here on all of these drugs that are listed onto the side. I think this just illustrates how many there are. And, you know, I was just looking through the ones that they put on here. I mean, at the top, I mean, we've got some that for ALL, we've got hairy cell leukemia, we've got some solid tumor stuff here. For example, sacituzumab govitecan is actually kind of an exciting one. It's the first targeted therapy we've had for triple negative breast cancer, which had been unheard of for a very long time. What are some other ones we have on here? Belantamab mafodotin is targeted towards myeloma. Padcev or palatuzumab vedotin is targeted towards bladder cancer. So yeah, it's been exciting. One I think hospitalists are more familiar with is trastuzumab. We all know Herceptin, which targets the HER2 receptor on HER2 positive breast cancer. We've been using Herceptin since the 2000s. And again, we realized we could attach some chemo to that and send that more directly to the cell. And as we'll get into a little bit more, this whole trastuzumab deruxtecan entity here is going to come up more, because not only do we have our initial approvals for that in the breast cancer world, but we have been discovering HER2 expression on a lot of other tumor types, most frequently with upper GI cancers, such as esophageal and gastric cancer. And for that reason, when we're able to find HER2 in those patients, this trastuzumab deruxtecan is starting to work its way into the treatment paradigm. All right, moving forward. All right, so we just reviewed some of the different classes of drugs that we're going to be talking about today, and now we're going to start talking about the bad things that they can do when we give them to patients. So looking here, we're talking about just immune-related adverse events. I think a lot of us are pretty familiar with this. Spend a year or two in the hospital, you're going to see these patients come in with, pneumonitis, colitis, hepatitis, dermatitis. What I usually describe to patients when they're asking me, I'm getting an immune therapy, that means that I'm not getting chemo, that means I'm not going to feel bad, that means I'm not going to get sick. I always try to explain to them that, yeah, you don't have the typical side effect profile that you have with chemotherapy. That does not mean that it's not without toxicity. Yes, usually people will tolerate it much better, but we still have issues. And I usually explain to folks that anything in the body that could possibly have the suffix itis applied to the end of it, you can have that side effect. Anything that can have an itis and get it inflamed, you can have that side effect. And if you look on the right here, you see a whole bunch of itises. Just starting in the eye, uveitis, you can get Sjogren's syndrome, dry eyes, retinitis. Pneumonitis is one of the things that kills people. That's one of the things we want to be aware of. Hepatitis, extremely common. Pancreatitis, not as common, but I've seen it. Any kind of renal inflammation, colitis can be quite detrimental. The skin rashes are very common. I actually had a patient last week who developed some dermatitis related to pembrolizumab or Keytruda. We'll talk about treatment in a bit, but these rashes tend to be very steroid responsive. I saw this guy yesterday after he'd been on steroids for a week, and the rash had essentially disappeared. Encephalitis, that can be devastating. Hypophysitis, so any kind of endocrinopathy can manifest in whatever ways. Myocarditis, of course, can be devastating. And then I mentioned we don't have the same side effect profile with this that we do with chemotherapy, but myelosuppression, just like we see with chemo, is still a real thing with these drugs. So you are still, possibly going to see, depressed bone marrow, resulting in anemia, neutropenia, low platelets. So those are things to keep in mind. Thrombotic microangiopathy, I have seen that. That is kind of interesting. Just to review, when we talk about thrombotic microangiopathy, we're talking about entities such as TTP or thrombotic thrombocytopenic purpura or atypical HUS, hemolytic uremic syndrome. I have seen that happen. Rare, but it's something to think about. Of course, you'd be getting your friendly hematologist involved in that situation. I have not seen acquired hemophilia, but theoretically it could happen if you developed some antibodies to factor VIII. And then more itises, arthritis, myositis, dermatomyositis, arthralgias. Suffice it to say, clearly it's a relative contraindication. I say relative. Oftentimes it is a strong contraindication if someone has an underlying autoimmune condition. But that's something we can get into in a little bit here. So frequency of these events. So the agents used, yes, different immune therapies can lead to different incidences of these problems. For the most part, if you look at the PD-1, PD-L1 inhibitors, Nivo, Atezo, Pembro, for the most part, they're having pretty similar incidences. If you look at the clinical trials of these drugs, almost 50 to 60% of the patients are going to have some degree of an immune-related adverse event. Most of those are going to be grade 1, grade 2. Again, the ones that we worry about are the ones that are very harmful and put people in the hospital and can be life-threatening. And those are grade 3 or 4s. You definitely see a higher incidence of those with the CTLA-4 inhibitors like ipilimumab or tremelimumab. But even more so, it's when those things are used in combination. We have the most experience with the combination therapy, such as with Nivo, PD-1, and IPI, CTLA-4, in the melanoma literature. For example, one of the standards of care is to give them 4 cycles of combination CTLA-4 plus PD-1 and then put them on maintenance Nivo. Well, a lot of folks don't even get through all 4 of those cycles of the combination because they end up manifesting bad immune therapies or immune therapy related events. So the combination is really when we see the worst, or the term we use is dual checkpoint blockade if you're wanting to get fancy. Exposure time, yeah, that is something to take into consideration as well. But one thing I've noticed is it is extremely unpredictable when these problems are going to manifest. You could have folks that have an issue right after the first dose. You could have folks that have an issue after 6 or 7 doses. You could have folks that completed a year of therapy and don't manifest anything until 6 months after they stopped. So it's very unpredictable as to when these things are going to happen. I had a patient last month who got 1 dose of Keytruda in the adjuvant setting for a renal cell carcinoma. 3 weeks later, he ended up in the hospital with pneumonitis and is still on a ventilator. So it's very unpredictable. Also, this patient didn't have any warning signs for this happening. He didn't have any history of autoimmune disease or anything like that. So that is something to think about. Administered dose, to some extent, you can see it with higher doses. A lot of these drugs now, we used to do them weight-based, like we do with a lot of chemos, but actually they're all, for the most part, flat doses nowadays. But sometimes some of these drugs can be administered, at different intervals, like every 3 weeks or every 6 weeks. And we do see some higher incidence with the every 3-week regimens. And then I mentioned earlier the patient intrinsic risk factors. Some folks with have autoimmune disease, such as rheumatoid arthritis, lupus, those are folks that you would have hesitancy or more likely just say, hey, I'm not going to give this drug to those folks. There are some people that have autoimmune diseases that just don't have that bad of symptoms where you can do a little bit of risk benefit on that and say, hey, I'll give it a shot. But for the most part, if someone has a very, strong history of autoimmune disease, we're not giving these drugs to those folks. All right. moving on. Oh, one other thing I wanted to mention, intrinsic risk factors. Another thing we've noticed, especially like in the lymphoma world, patients that have a much higher disease burden, for example, if they've got very diffuse bulky adenopathy all over their body, some of those folks that have a higher disease burden are going to have a higher risk of developing these immune-related adverse events. So that's something else to keep in mind. And then one final thought is, in the literature, there actually is some evidence that the patients that have very robust responses and have terrible immune-related adverse events, some of those people end up actually responding better with regards to their cancer and having better efficacy. That being said, you're still not going to give them the drug again, but it is food for thought. So looking at this, I think this is very relevant to what we're talking about today, is looking at total hospitalizations in this study compared 2012 to 2018 on the left. That's just hospitalizations across the board at this one study they did. And you can see going up, but the immune-related adverse event hospitalizations in the middle, and the percentage of the hospitalizations on the far right, those peaked in 2018 and started to go down. Just reviewing that, I would like to think that this is indicative of the fact that we've gotten better at managing these issues in the outpatient setting, and not as many folks are having to get admitted. I think most oncologists practicing today are giving a lot of immunotherapy, and you give a lot of immunotherapy, you see a lot of immune-related adverse events, so you get used to managing it. So I do think we're getting better at managing it. You'll notice when they break it down by tumor type, by far the largest number of folks getting admitted to the hospital for immune-related adverse events are folks with lung cancer. I think there's two reasons for that. One being it's one of the more common things that we give immune therapy for. I mean, standard of care first-line therapy for lung cancer is a combination of chemo and immunotherapy, regardless of what your PD-L1 score is on your tumor cells. So the vast majority of patients with metastatic lung cancer that don't have a clear contraindication, they're all getting immunotherapy. And then I think the other reason that the majority of these folks are lung cancer is, just at baseline, lung cancer patients are really sick, and it doesn't take much to push them over the edge and put them in the hospital. But just something to think about. But I mentioned all these folks with metastatic lung cancer are getting immunotherapy with their chemo, regardless of what their tumor expression of PD-L1 is. Well, we're starting to see that with more and more malignancies in the solid tumor world, these kind of tumor agnostic things where folks are just getting PD-L1 inhibitors added on to their chemo, regardless of what we're seeing in the tissue. So long story short, you're going to be seeing a lot more of these. Looking at the frequency of the grade 3 or higher adverse events. As we were talking about earlier, the third box here, the immune checkpoint inhibitor combinations clearly have the highest incidence of the grade 3 or more adverse events. 55% of folks are going to experience them. Over on the far left, only about 14% of folks getting single agent PD-L1 will have that. CTLA-4, a little higher incidence. And then over here, 46% with the immunotherapy, chemotherapy combination. Those are those lung cancer folks, for example, I was mentioning earlier. And here, I've been alluding to this as well, increased use of adaptive cell therapies. It's very clear to see by all these charts that there's been a tremendous uptick in the studying of and use of these agents in very rapid fashion. I mentioned 2011 earlier being the first approval for melanoma with ipilimumab. And since then, this has gone up precipitously. Clearly the green here being the largest chunk in all of these because it's phase 1, because those are the easiest to do. Phase 3s are harder to come by, but they are getting done. You can really see that they're ticking up here in the late 2000s, and that's where we are getting the majority of our drug approvals. And then down at the bottom, we're looking at our CAR T trials for hematologic versus solid tumor. And the heme side of things has really had a head start on the solid tumor world as far as CAR T. We have multiple approvals in the hematology world for CAR T, as I mentioned earlier, lymphoma, ALL, and most recently multiple myeloma. And you can see a breakdown for some of the targets there. The CD19 on the right, that's the one that we see for lymphoma, and that's why the most of them are there. But BCMA, we do for myeloma. But CAR T for solid tumors, we are looking high and low for good targets for CAR T in the solid tumor world. Don't have a whole lot of success yet, but we're working on it. I'm actually one of the investigators on a CAR T trial for pancreatic cancer here at Baylor in Dallas. And, you know, we're enrolling folks and we're getting stable disease in a lot of folks. But the big challenge is finding good targets. And one of the big problems with solid tumors compared to the heme malignancies is that the solid tumors often have multiple targets. So you target one, you're really not shutting the whole thing down, as you know, this maybe not so much the case with the hematologic malignancies. So adverse events, cytokine release syndrome, CRS, you've heard of this, we know of this, it's important. So cytokine release, we see it with CAR T therapy. We also see it with other types of cellular therapy, more specifically the bispecific T cell engagers. And essentially it is hyperinflammation, T cells going into overdrive, the immune system doing its job way too well. So you can see this kind of symptomatology in the hospital a lot for a lot of different things, but the things you're going to see are fever, low blood pressure, tachycardia, hypoxia, chills. On the surface, it sounds a whole lot like sepsis. And then serious events, you know, refractory hypotension, requiring pressors, people getting hypoxic, requiring ICU management, ventilation, arrhythmias, ventricular tachycardias, people going to have cardiac arrest, cardiac failure, renal insufficiency, going on dialysis, capillary leak syndrome, where you just get huge leak of fluids. You can get anasarca, you can get more hypoxic and pulmonary edema, and then the dreaded HLH, MAS. HLH is hemophagocytic lymphohistiocytosis, and MAS is macrophage activation syndrome. Just think of it as the immune system on overload. This can typically happen about 2 to 3 days after the patients get their cells, and you can actually see it happen just within hours of the infusion. I have seen that happen, and it can be as much as 15 days after the infusion, and it usually lasts for 7 to 8 days. There is, similar to what I was talking about with efficacy of immune therapies and immune-related adverse events, there is some literature saying that with CAR T therapy, the patients that develop some degree of CRS tend to have better outcomes as far as response of the tumor. And sometimes we get a little bit worried if a patient didn't even have a touch of CRS. You think, well, maybe those cells were not as effective as we anticipated they would be. So the other thing that we watch out for, other than CRS when it comes to these cellular CAR T therapies, is ICANS, immune effector cell-associated neurotoxicity syndrome. We'll just keep drilling this in. CRS and ICANS. CRS and ICANS are the two big things we watch for. Symptoms to see: delirium, aphasia, lethargy, headache, tremor, myoclonus, dizziness, motor dysfunction, ataxia, sleeping disorders, anxiety, agitation, signs of psychosis. Pretty vague symptomatology, covers a lot of ground there. We see that in tons of patients that are in the hospital that are not getting these therapies. But we need to have a very low threshold for concern in these patients. In fact, patients that are getting these CAR T cells, you know, of course, they're in an institution that, you know, takes care of patients with CAR T cells. They have protocols in places. The nurses are doing neurochecks on a regular basis throughout the day to ensure that these issues are not transpiring. Of course, serious events would be seizures, depressed level of consciousness, and some people can have fatal cerebral edema. So something to be very vigilant of. Typical time to onset, 4 to 10 days. Typical duration, 14 to 17 days. In comparison to CRS, which I mentioned can happen, you know, within hours or days of getting the cells, ICANS, or the neurotoxicity, tends to occur a little bit later than the CRS, and it can also last a little bit longer. And we're going to talk about in a bit the treatment of these things specifically. And now going on to the antibody drug conjugates and the bad things they can cause. Well, the bad things they can cause are all related to the payload, to the chemo that is attached to the antibody. There are some specific side effect profiles that we watch out for. For example, with ozogomycin, that can cause VOD. In the hematology world, the other word we use for VOD or veno-occlusive disease is sinusoidal obstructive syndrome, or SOS. Long story short, blockage of small vessels in the liver can lead to liver failure. That's actually why this gemtuzumab ozogomycin for leukemia patients is actually relatively contraindicated if they go to transplant. The transplant doctors do not want patients getting this drug first because the risk of those people developing VOD or SOS post-transplant is very high. Vedotin, which is the payload attached to a host of things here: brentuximab, polatuzumab, enfortumumab. Most commonly brentuximab in the hematology world with a drug called Cetrus, brentuximab vedotin. It causes neuropathy. Tons of patients get neuropathy from this. Almost everybody gets some degree of neuropathy from that. And of course, myelosuppression. Again, I don't think it's necessary for hospitalists to know the specific side effect profiles of these different antibody drug conjugates, but it is important to know that they can cause problems and they can cause a variety of different problems. And it's always a good idea to know if your patients are on one of these drugs, because you can quickly get on up to date and check and see what the more common side effects are, more common adverse events are, and pretty quickly determine if what your patient is experiencing is potentially related to their cancer therapy. Even more of a list here, don't have to commit all this to memory, but like, for example, the one at the top, mafodotin with belantamab mafodotin, we give that for multiple myeloma, and every single patient that gets that drug goes to see an ophthalmologist before they get it, and they get regular ophthalmology exams because the keratopathy is so common. That one really stands out. And then another one we want to highlight, and we're going to talk about more later, is the second from the bottom with the trastuzumab deruxtecan, aka Enhertu. And that's what we give in the HER2 positive breast cancer setting, as well as I mentioned earlier. We're seeing it in upper GI malignancies that express HER2, such as esophageal and gastric cancer. And there is a black box warning with that drug that you can develop interstitial lung disease or pneumonitis, and it can be life-threatening. And I do think that's something that not only all oncologists that are taking care of these patients in the clinic need to be aware of, but I think it's important for hospitalists to know that some of these antibody drug conjugates, and specifically this one, trastuzumab deruxtecan, can cause issues like this because it can be life-threatening. And the indications for these are starting to widen even more. More and more people are going to be getting these drugs. So interstitial lung disease and pneumonitis, cute picture on the side here about the different patterns of, that you can see with ILD and pneumonitis, but all of you have seen this for different reasons. Fatigue, shortness of breath, dyspnea, dry cough, chest pain, fever, skin rash, relatively non-specific symptoms. But again, if you have a patient that is on one of these drugs, you would have a very low threshold for concern. You might say, hey, what is that patient getting? Does the patient remember what they're getting? Try and talk to their oncologist. Figure out if they're on one of these drugs so you can take appropriate action. Tumor lysis syndrome. We all know tumor lysis syndrome going back to residency, med school, but it's always important to review, especially as hospitalists, I think more and more taking care of patients that are at risk for tumor lysis. I don't know at your institutions what you guys do, but our hospitals here are rounding on our leukemia patients in conjunction with us hemonc docs. So they're very regularly encountering tumor lysis. I really like the pictures that they included, particularly the one up on the top left. Those test tubes up there are apheresis or leukapheresis, more specifically, leukapheresis samples from a patient with acute lymphoblastic leukemia. And it's hard to see because you really only see one component most prominently. But at the very top, you have that kind of clear yellow. That's the plasma. At the very, very bottom is a very small dark layer of RBCs, and that big chunk in the middle is all leukemic cells. That is that murky yellow is all leukemic cells, and that is, just looking at it in a bottle, very high risk for TLS. Pretty clear. On the right, you have a lymph node section from Burkitt's lymphoma. Long story short, we know that lymphoma is something that can cause, high risk for TLS. Burkitt's would be at the top of that list just because it's so proliferative. The cells divide so fast, and on top of that, they're very chemosensitive. So you give them chemotherapy, cancer kind of melts away very fast. It causes rip-roaring TLS. The solid tumor, correlate for that would be small cell lung cancer, is another one where you have a very high risk of tumor lysis syndrome, especially when you start people on chemotherapy. So just kind of reviewing pathophysiology here without getting into too much detail. We know that when these cells lyse or break, they release toxins, or entities that are toxic to the body in excess, specifically DNA, electrolytes, phosphate, potassium, and cytokines. So the DNA gets broken down all the way to xanthine, which xanthine oxidase breaks that down to uric acid. Uric acid causes all of its problems if it accumulates too much and is not excreted appropriately. As you can see, as the arrow goes to the right, you get accumulation and you get TLS, you get kidney injury, and you get a cascade of bad clinical outcomes. And the other issue with accumulation of phosphate, accumulation of potassium. And then I like that they included the cytokine portion on the far right, because not only are we seeing the release of DNA, phosphate, potassium that cause metabolic problems and clog up kidneys, et cetera, but you do just get a whole lot of inflammation with the release of these cytokines from the breakdown of the cancer cells, which can lead to hypotension and in turn precipitate and exacerbate the AKI. And the interventions we're all very familiar with are allopurinol, which inhibits the xanthine oxidase, which ultimately in turn inhibits the production of uric acid. And then you have respiricase, which acts by a very different mechanism, and that essentially increases the metabolism of uric acid to allantoin, which can be appropriately handled by the body without leading to TLS. One important point I want to bring up about respiricase: if your patient does not have an elevated uric acid, respiricase is not going to do anything. So for example, we have a patient that comes in with Burkitt lymphoma and they have a very high risk of TLS, and we're concerned that they're going to develop TLS, so we're going to put them on some allopurinol prophylactically. Their uric acid is normal, but we still feel like, prophylactic allopurinol. But if their uric acid is normal, if they have uric acid of 3, if you give them respiricase, that's not going to do anything, because the whole purpose of respiricase is to metabolize high levels of uric acid. So the only thing that you're going to accomplish is by angering the pharmacy, because you just wasted tens of thousands of dollars on a dose of respiricase. Usually, if you try to do this, you will get a phone call from the pharmacist, but just FYI. I've been there. TLS. Okay, so here's some laboratory definitions. We all know this. Hyperuricemia, uric acid greater than 8 in adults. Hyperphosphatemia with a phosphorus greater than 4.5, hyperkalemia, and hypocalcemia. So when I was a medical student, I always was forgetting the hypocalcemia, and I think people forget that a lot as well. And then, of course, AKI. So that's your clinical picture. Looking at folks with these abnormalities, they can develop cardiac dysrhythmias, sudden death. Particularly, we get concerned with hyperkalemia. We all know how to manage hyperkalemia. Be very cognizant of that. Hypocalcemia can also lead to the dysrhythmias, sudden death, neurologic issues such as seizure. And don't forget from medical school, your Trousseau and Chauvet sign, Trousseau being the carpal pedal spasm with the blood pressure cuff, and the Chauvet sign eliciting the twitching of the facial muscles. I'm curious if any of you guys have elicited either of those recently, but if you haven't, go give it a try. Let's see. Risk stratification for TLS. This just lumps folks into 3 categories: low, intermediate, and high. I alluded to this a little bit with regard to the type of malignancy. We kind of have a spectrum. Low risk disease would be more of our solid tumors. Looking at hematologic stuff, multiple myeloma, CML, CLL, those are hematologic malignancies that don't have very high proliferation rates. They're indolent disease for the most part. You don't have cells growing at a rapid pace, and consequently, you don't have cells that melt away very quickly, so to speak, after treatment. So that is a lower risk for TLS. Of course, indolent non-Hodgkin's lymphoma, that would include things such as follicular or marginal zone lymphoma, or certain low-grade mantle cell lymphomas. Hodgkin lymphoma can fall in that category. And then AML, a lot of times, I don't know if I would ever put AML into a low-risk category. I think there always is a propensity to have some degree of clinically significant TLS. And you'll notice in the hospital, regardless of what their white blood cell count is, we're usually putting them on prophylactic allopurinol at least, every single one of them. But yeah, you can risk stratify them to some extent with WBC greater than 25,000. Clearly, an AML patient that has a WBC of 100,000 is going to be at a lot higher risk for TLS compared to someone less than 25,000. We also tend to see a higher risk of TLS in certain subtypes of AML, like APML or acute promyelocytic leukemia. Food for thought, also has a higher risk of DIC. That can be life-threatening, but that's not part of this talk. And then intermediate risk, you can just see AML with a little bit higher white count. ALL, again, it's more of a bad actor. But again, the big thing here, Burkitt lymphoma, again, they had that picture there earlier. Burkitt lymphoma is just notorious for having very bad TLS, and not listed on here. The dreaded small cell lung cancer is the other one we see. And I do think that's worth noting, because small cell lung cancer is one of the very few solid tumor malignancies that us oncologists will actually give chemo to in the hospital. So that is something you might see. And over here, as far as prophylaxis, we talked about adding allopurinol to all these folks. Even with low risk disease, we consider it. I said I put it on everyone with AML. Their guidelines are directing us to do allopurinol for an immediate risk disease. Of course, you want to have adequate IV hydration and urine output, and you need to be monitoring TLS labs, specifically calcium, phosphorus, potassium, Q8, Q12 hours, and then monitoring for high risk disease every 6 to 8 hours. But the big thing here is respiricase. I remind you, respiricase if the uric acid is high. So initial evaluation for fever and neutropenia. I think this slide is bread and butter hospitalist stuff. We are all very good at this. It's one of the most common things that we do. But let's review this. For fever, a single temperature that's greater than 38.3 degrees centigrade. If anyone wants to write out their centigrade to Fahrenheit formula and tell me what that is in Fahrenheit, by all means, go for it. And then, or equivalent to 38.3 centigrade orally over a 1 hour period. And then neutropenia, as we define, is less than 500 or less than 1,000, that we expect it to decline to less than 500. We'll talk about this more in a bit, but one of the most important things when assessing febrile neutropenia and the risk thereof is going to be the duration of neutropenia. For example, leukemia patients that just had induction chemotherapy, they're going to be neutropenic for 2 weeks or 2 to 3 weeks, are at much higher risk of devastating febrile neutropenia than a patient that is on every 2-week chemotherapy for colon cancer that is getting, maybe 3 or 4 days of transient neutropenia between cycles. So that's important. The more prolonged the neutropenia is, the bigger of a deal it's going to be. So what do we want to do? We do what we always do. We do a complete H&P, and that includes a supplemental history. We want to assess what their other comorbidities are. Do they have heart disease, kidney disease, underlying lung disease? Do they have autoimmune problems, immunodeficiencies outside of their cancer and their treatment that they're getting? We want to know when their last chemotherapy was. I don't know how it is at your hospital. One thing that's challenging here is our oncology outpatient side uses a completely different medical record than the inpatient side. We don't use Epic. The hospital uses Epic. Hospitalists can't see our records. It's a whole issue. If you ever have a problem, please pick up the phone. I hope that your local oncologists are as friendly as we are here. We are happy to let you know, A, what the patient's diagnosis is, B, what they're getting and when they last got it, because the timing is going to be very important. Depending on the chemo regimen, oftentimes we see, a nadir neutropenia count between maybe 7 to 12 days. So if someone just had chemo like 2 days ago, very unlikely that they're going to, have neutropenia related to that. Or if someone hasn't had chemo for, 2.5 to 3 weeks, extremely unlikely that they're going to have neutropenia related to that, unless it was, a big heavy duty induction regimen, such as for AML. So we want to know if they've had prior documented infections in the last 3 months. We would like to see, what those cultures were, what the susceptibilities were these people on any antibiotic prophylaxis or actual therapy? What are their other medications? Do any of these medications outside of the chemo drugs cause immunosuppression or increase susceptibility to infection? And do the patients have any devices? In our world, that would be indwelling catheters. Do they have a port? Do they have a PICC line? And then also, do they have epidemiologic exposures? Are they smokers? Are they IV drug abusers? And then, of course, what do their labs show? CBC with diff, got to check the ANC, CMP, and then, of course, consider chest ray or urinalysis. You want to get blood cultures. We all know we want to get 2 of them, one peripheral, one catheter. Urine cultures, if they're having symptoms specifically, and then depending on their symptoms, of course, these site-specific diagnostics, check for C. diff. Your lab will not accept a sample if it's not liquid. Don't try if it's not, and monitor for skin bugs, viral, etc. Initial risk assessment. So I like this slide. At the bottom here, they talk about this mask risk score, and we talked about it in the first question. And it's not something that I have used on a regular basis. But just reviewing the stuff that it entails, I do think that it is helpful. There'll be a slide on this in a second, but basically it's assessing, what their burden of illness is, what are the clinical issues, are they hypotensive, what's their type of cancer, is it a solid tumor, is it hematologic, do they have, history of COPD, and those are things to keep in mind. I think there's one small typo on the slide because low risk is correct here as far as the mask risk index score greater than 21 and a CSNE score less than 3. And on high risk, it would be less than 21 and CSNE score greater than 3. But I digress. And these are the things you want to assess to distinguish between low risk and high risk, because that's going to establish what you do and where you do it. How are you going to treat them? Are you going to keep them out of the hospital? Or are you going to put them in the hospital to manage them? I can tell you, as an oncologist, cancer patients, I am always looking for reasons to be able to keep my patients out of the hospital. We all know that folks can deteriorate in the hospital, but it happens. So looking here, outpatient status at time of development of fever, what other comorbidities do they have? Kidney, liver, heart, lung. Here it's listed here, duration of neutropenia. I talked about the importance of duration here at less than 7 days. Of course, greater than 7 days is going to be a much higher risk. What is their functional status? Do they have a good performance status? What's their reserve? Do they have hepatic insufficiency, renal insufficiency? All that has to be taken into account. You guys know how to assess if these folks are sick or not, and if they don't have a good substrate to recover. Poor renal insufficiency. Do they have underlying lung issues? Do they have grade 3 or 4 mucositis that's going to require more aggressive care, IV fluids, et cetera? And that's going to determine low risk, try and manage them outpatient, consider sending them to an ambulatory clinic, or maybe in the hospital in certain situations. And these high risk folks, they're going to put them in the hospital. So management tools. Yes, these NCCN management tools I think are really great. There's multiple out there, and we're going to stick to these. I will make a plug. There is an excellent app called CarTox, C-A-R-T-O-X. It's from MD Anderson. And CarTox is an app from MD Anderson that lets you assess immune-related adverse events related to CAR T therapy. And it has excellent algorithms, very easy to navigate to assess both CRS and ICANS. And I can tell you that everyone at my hospital that takes care of CAR T patients uses it. Everyone I know at other hospitals in the area that takes care of CAR T patients uses it. And it's very similar to this, but CARTOX, C-A-R-T-O-X, it's a free app. It's excellent. So these management tools for immune-related adverse events. So this slide in particular is looking at immune-related adverse events as it is in regard to immune therapies like PD-1, PD-L1, CTLA-4. So this is not really where CARTOX is going to fall in. That'll be on later slides. But this allows you to look what organ system is involved. Is the patient coming in with a rash? Is it a dermatologic issue? Is it an endocrinopathy? Is the patient coming in with new adrenal insufficiency or new diabetes? Sorry about that. Is the patient having GI issues, diarrhea, or are they having musculoskeletal problems and new arthritis, myositis, et cetera? Are they confused, neurologic, pneumonitis? So in this example, they clicked on thyroid. It's prompting you to choose tell them what the TSH is, you provide some clinical data, and then it spits out some excellent recommendations. Of course, depending on the grade of the toxicity, that'll tell you, do you continue the immunotherapy? Do you stop the immunotherapy? What do you do to address the actual endocrinopathy here? Do you give them Synthroid? How do you dose their Synthroid, et cetera? That's very helpful. Here for the CAR T-related CRS, this is where the CARTOX app would really come into play. But looking at the 4 grades here, the way we look at it is, and this is standard across the board for cytokine release syndrome. Grade 1 is just with a fever greater than 38 centigrade. Grade 2 is going to be fever with the combination of low blood pressure, not requiring pressors, so responsive to fluids. And then grade 3 and 4 is where we get nervous. Grade 3 is going to include fever with hypotension that requires a vasopressor, with or without a hypoxia. That's requiring high flow nasal cannula, face mask, non-rebreather, Venturi. And then grade 4 is when we get into fever, refractory hypertension requiring pressors, and patients requiring positive pressure support for hypoxia, either that CPAP, BiPAP, intubation, mechanical ventilation. I do think it's important for us to realize, because I think I overlook this sometimes as well, that new requirement for CPAP is going to put you in grade 4. So any positive pressure oxygen supplementation that's occurring in the setting of fever and hypotension refractory pressors, that's putting you in grade 4. And looking at what you do for each grade, we have our 3 categories of intervention here, our anti-IL-6 therapy, corticosteroids, and additional supportive care. So looking at anti-IL-6 therapy is tocilizumab. That is standard of care across the board for management of CRS, cytokine release syndrome, in patients receiving CAR T. It is mandatory that any hospital that's allowed to do CAR T has a pharmacy with tocilizumab in stock. You cannot give CAR T without having it on hand. So very, very important. And usually with grade 1, if they're just having a fever, you don't necessarily need to give them tocilizumab. You can just do supportive care. You can just monitor them. Consider steroids, consider toci. Don't necessarily need it. Supportive care, fluids, symptom management. You do want to screen them for sepsis like you would anyone else with a fever in the hospital. It's not wrong to start them on empiric broad spectrum antibiotics because we know that these folks are going to have, to some extent, some immune compromise. So low threshold for that. You can consider GSF if they're neutropenic. I think a lot of folks would avoid using GSF up front just because there is somewhat of an increased risk of pneumonitis if you give them GCSF right after you gave them CAR T. But that's not a hard contraindication. Maintenance IV fluids, we all know this. And then symptomatic management of organ toxicities, we all know this. So grade 2, again, it's low threshold. That's when you're going to give the toci. Very low threshold to give tocilizumab. And that's going to be any manifestation of hypotension. Even if they respond to fluids, go ahead and give them the tocilizumab. It's never going to be wrong. It is expensive, but the pharmacist will not yell at you like they would about Respirocase because it's a life-threatening condition with a potentially life-saving intervention with the tocilizumab. You can consider dexamethasone, but again, management, fluids, monitor the cardiac status, get EKGs, troponins, just like you would in any other situation that was manifesting like that, regardless if they got CAR T. And now moving into the grade 3 That's going to be fever, hypotension, requiring vasopressors. Of course, they're all getting the IL-6 inhibitor. They're all getting TOSI. They're all going to the ICU. You're going to go ahead and just give them steroids. Same thing with grade 4. So again, low threshold to give the tocilizumab. Now, different hospitals have different protocols. I know that currently at my hospital, the patients that are getting tocilizumab are actually just on the hematology service, and our hospitalists are not regularly rounding on them. But I'm actually in the process of giving a very similar lecture I'm giving now to our hospitalists here, as far as getting them trained to manage this. I honestly think that hospitalists have every reason to be managing this because, a lot of hospitalists are already managing leukemia patients that have neutropenic fever, et cetera. And yes, this is a new entity, CAR-T, CRS, tocilizumab, but I don't think it's any more complicated. And I think it's something that all of us should be handling. But anyway, we'll see. I'm sure your institutions are all pretty different. ICANS. So the big difference between CRS and ICANS, or neurotoxicity management, is CRS is tocilizumab plus minus steroids. ICANS is steroids. Tocilizumab in the setting of a pure, neurologic issue related to the CAR-T, meaning they don't have any other CRS symptoms, they don't have fever, hypotension, etc. If it's purely a neurologic thing, tocilizumab, IL-6 inhibition does not play a role. Dexamethasone is the standard of care. Okay, and we talked a little bit about these manifestations as far as depressed level of consciousness, seizure, motor findings, elevated ICP, cerebral edema, the ICE score, that's actually in the CAR-T app, and that is actually had it pulled up here. So in the CAR-T app, the ICE score to assess for the immune effector cell-associated encephalopathy, you look at several different domains. You look at orientation, naming, are they following commands, writing ability, and attention, and you can get a score there. And that all plays a role when you combine that with the other clinical findings of consciousness, seizure, motor findings, elevated ICP. Mentioning the ICP, low threshold for brain imaging, because that's going to be one of the best ways to assess for ICP, unless one of you is a very astute bedside clinician in the Oslerarian tradition and can do an ophthalmologic exam and let me know if there's papillary edema. But I imagine most of you haven't done that in a while, but I'd be impressed. And then moving on, management approach to ICANS. Already kind of talked about this. The bread and butter thing here is going to be the dexamethasone. And you look over to the right, additional therapy if concurrent CRS, that's going to be tocilizumab. So again, tocilizumab does not play a role in the CRS, in the CAR-T related neurotoxicity, unless there are separate manifestations of CRS, fever, hypotension, etc. And then, of course, you want to do regular neuro assessments as outlined here at the top. MRI brain, I mentioned. If you want to look for cerebral edema, you can also screen for that with CT. They recommend neurology consultation at first sign of neurotoxicity. Never a bad idea if you've got them on hand. Getting EEGs if you have seizure activity. There's not necessarily a role for upfront seizure prophylaxis in these people. That might change down the line. Of course, aspiration precautions if there's a decreased level of consciousness, IV hydration, and then be mindful of any drugs that could cause some respiratory depression that could potentially exacerbate this, i.e. narcotics. Management of ILD and pneumonitis. So we've been talking a lot about this earlier as far as the risks of pneumonitis and ILD, both with immunotherapies, be those PD-L1 inhibitors, PD-1 inhibitors, CTLA-4, but also with antibody drug conjugates, one of the big offenders being trastuzumab deruxtecan or Enhertu. And here is one of the guidelines more specifically for Enhertu. So if these folks on trastuzumab and tansine, if they get grade 1 pneumonitis, that's just going to be asymptomatic. So that's going to be incidentally seen on a scan. And we do see that, we have people on treatment, we give them 3 cycles of therapy. We get an interval scan to see how their disease is responding. And we incidentally end up finding that whoops, they've got pneumonitis or interstitial lung disease, but they're asymptomatic. That's grade 1. In that case, you can hold the drug, and the oncologists are going to be doing this. They won't be in the hospital, but we hold the drug until we get repeat imaging, and it's grade 0, meaning we don't see it. And then you can consider restarting the drug. Pretty clear though, if it's grade 2 or higher, meaning they are symptomatic, you don't mess around with that drug anymore, and you give them steroids. So if they end up in the hospital, just know that they're going to be getting corticosteroids. That's typically dosed 1 mg per kg per day, prednisolone equivalent, and they're going to be on it for at least 2 weeks, and it is a slow taper over a month. That would typically be out of your purview. It would be in the outpatient setting. But you can see that we don't mess around with this. If they have any radiographic findings of ILD or pneumonitis concurrently with symptoms, they don't get the drug anymore. And for the most part, that's a similar approach to immune therapy as well. Tumor lysis syndrome, we all know this. We've all done this. So I assume we've all done this. We know that prophylaxis is allopurinol, 300 milligrams once daily is the standard dose there. All of our leukemia patients get this in the hospital, even prior to starting therapy. And then some solid tumors, like I mentioned, small cell lung cancer. You want very strict I's and O's. You want to make sure that you're giving them isotonic fluids. 100 to 200 cc's an hour. I think more important than what you're giving them is what you're getting out. Therefore, you really want to make sure they have a good urine output, target urine output, 2 liters per day. I know that different floors in the hospital have different levels of proficiency when it comes to I's and O's. That's why I would recommend anyone that is at high risk for TLS, especially if they're getting treatment for leukemia, is on a hemonc floor. But I've even seen different levels of proficiency on I&O measurement there as well, but I digress. Telemetry monitoring, because we know with these electrolyte derangements, they are at risk for having potentially life-threatening arrhythmias, dysrhythmias. And then, of course, monitoring of TLS labs. General recommendation is low-risk patients every 12 hours and high-risk patients Q6 to 8. And if they are high risk and or uric acid greater than 8, then give respiricase. This is my favorite line on the slide. High risk and or uric acid greater than 8. So if I had a magic wand, I would wipe out the or there. It's high risk and uric acid greater than 8. You are not going to be able to give that drug if uric acid is normal, or the pharmacist is sleeping on the job. And then only treat symptomatic hypocalcemia. That's pretty standard. Let's see. Management of neutropenic fever in patients with cancer. Again, bread and butter, hospitalist stuff. Over on the left, it shows the MASCC score, which I was talking about earlier. This just lists some of those. Again, this is not something I've used regularly, but I actually kind of like it. I might start incorporating it. Burden of illness. Are they having mild symptoms? Are they having moderate symptoms? Are they hypotensive? Do they have a history of COPD? Solid tumor or hematologic malignancy with no previous fungal infection, no dehydration, outpatient status, less than 60 years. So, and all of these have different weights. And, a high score, so MASC greater than 21 is low risk, and MASC less than 21 is going to be high risk. So that is the beginning of your triage assessment for these patients with neutropenic fever. And then working down the line on the left, the low risk folks, you can, as I mentioned earlier, can typically manage them outpatient. So you guys won't see them. We'd get blood cultures, we'd work them up, see if we can find where the source is. IV antibiotics, first dose, give them, we typically would do fluoroquinolones. Actually, a side note here, I had an older oncologist that I work with, been doing this probably since the 70s, and he told me the single best change in oncology practice for him as far as quality of life was concerned was, at least quality of life for the oncologist, was the development of fluoroquinolones, because it was for the first time they could get a call overnight for a patient with neutropenic fever, and if they were stable enough, they could just give them some fluoroquinolones, some levofloxacin, and send them home. Or in the old days, everyone just automatically had to come into the hospital. So anyway, the old oncologist that practiced before quinolones existed had a better quality of life. Moving on, we can observe some of these folks. Of course, we want to follow them up closely in clinic, but I'm going to skip to the right side because that's going to be more relevant to you guys. High risk, especially these hematological malignancies, especially HCT or hematopoietic stem cell transplant. These folks are going into the hospital. We talked about prolonged neutropenia. They're high risk. So you guys do your inpatient management, you get your blood cultures, you do your workup, you get your imaging as necessary, and you start your empiric antibiotics. You can see down here that they're really focusing on the gram-negative stuff. Cefepime is really preferable because we also have Zosyn, get some better anaerobic coverage. And then we all know if there is a history of extended spectrum beta lactamase, ESBL, you want to put those folks on Mirum. And usually if I'm going to that route, I would end up calling our friendly ID doctors. Management of neutropenic fever in patients with cancer. This is kind of the same thing. We have our low risk and high risk. Again, I'll really stick to the high risk because more of these folks are going to be in the hospital. But yeah, your empiric IV antibiotics, your cultures, getting ID if necessary, modifying the antibiotics based on what you see. So I think that puts us to the end of the lecture slides, and we are back into questions. We have Tom here. And I'm going to go ahead and read this off for you guys, and we will answer the questions. Tom is a 67-year-old man. He has a history of non-small cell lung cancer. He's on pembrolizumab or Keytruda, PD-1 inhibitor. He got his first treatment 6 months ago, so he's been on it for a while. And his last treatment was 2 weeks ago. He presented with 4 days of watery diarrhea. He's now having 9 to 10 loose stools per day and has significantly decreased his oral intake without improvement in his diarrhea. The guy is sick. So his labs has got a little bit of a leukocytosis, white counts 15 with a left shift. He has an AKI, his creatinine is 1.9 up from 0.8. Touch of hypokalemia with potassium of 3.1. Touch of acidosis with a bicarbonate 19 and chloride's 110. So what is the next best step in the management of this patient? The response is all right. We have check C. diff, stool PCR, and consult GI for endoscopy. 33% of us. Excellent. So that's what we would do in this situation. We talk about, kind of directed workup and therapy based on, what the clinical suspicion is. And in this patient, it's very possible that this guy's got an immune-related colitis. However, we would be doing him a disservice by not ensuring that he has C. diff or not. It would be a shame if we just put the patient on prednisone and didn't even investigate for an infectious cause and just let the C. diff proliferate. So excellent. It's good not to have blinders on. I think a lot of times patients that have cancer and are on treatments, a lot of clinicians, even oncologists ourselves, will forget that other things can happen. It's very easy to be biased and think, oh, the patient's on pembrolizumab, and the most likely thing that's going on is going to be, immune-related colitis. So it's important to check things like C. diff, common things being common, but also getting GI involved for colonoscopy is important because visual inspection of the colon is going to be the best way to actually diagnose immune-related colitis, and you can actually diagnose that on biopsy because you'll see increased infiltration of lymphocytes in the tissue. All right, next question. Yeah, C. diff PCR is, there's more to Tom. C. diff PCR is negative, GI consulted, but they can't perform the scope for 2 days because it's the weekend. We get scopes on the weekend here, but anyway, now what do we do? Music, please. Right. Very, very good. 30% for the steroids. Yes, this is someone I would go ahead and give steroids to. And yeah, IV methylprednisolone, 1 mg per kg per day. This is someone that is very appropriate to just go ahead and have a high, high concern for the possibility of immune-related colitis. Start them on steroids. They can still scope them if necessary when they come back after their long vacation, with the GI world. So yeah, I agree with that. Moving forward, here we have the NCCN management tool for colitis. We saw this earlier with the thyroid example. Here we clicked on GI, hepatic, pancreatic. It sent us over to the middle section where we put in some details. What grade is the diarrhea or colitis? And over here it gives us the recommendations. For grade 3, we're stopping the immune therapy, the anti-CTLA-4. So here you can consider resuming PD-L1 or PD-1 after resolution of toxicity. Just leave that up to the prescribing oncologist. If it's grade 4, we're of course going to permanently discontinue. And you guys nailed it on the inpatient care with the IV steroids. Yeah, one thing I didn't talk about earlier is if someone is refractory, there's actually a lot of research into this, into patients that are having immune-related adverse events that are refractory to steroids, and we're looking at things like infliximab or vedolizumab, but those are not without toxicity either. All right, Sarah, is a 48-year-old woman. She has a history of metastatic HER2-positive breast cancer, presented with a 1-week history of progressive shortness of breath on exertion and a dry cough. Currently receiving trastuzumab deruxtecan. That's the antibody drug conjugate attached to Herceptin. And it's under the care of her oncologist. Her last dose was 2 weeks ago. On exam, a little hypoxic, 93%. Oh, she hit on 4 liters, 93% on 4 liters. She's tachypnic with a respiratory at 28, and on auscultation, she's got bibasilar inspiratory crackles and leukocytosis, white count 19, left shift, normal creatinine, normal BNP, and her scan looks like this. No radiologists in the crowd, but we can assess this. She's also had a left-sided mastectomy. What are we going to do? All right, so we got some folks jumping towards an echo, giving some diuresis, got people checking blood cultures, sputum cultures, some people just going straight to pulmonary. I agree that the next best step, while we're considering these other things, would be to go ahead and start these steroids. I think with the patient's history and then the pulmonary findings on the imaging, which are actually a little startling, we would just jump straight towards the methylprednisolone. Again, this is somebody that is hypoxic. She's sitting in the low 90s on 4 liters nasal cannula and has very clear bilateral pulmonary inflammation there. So I'm starting the steroids, and the oncologist figuring out another drug to treat the breast cancer with would be the best thing to do. All right, John, 52-year-old man. He has a history of relapsed diffuse large B-cell lymphoma. He's admitted to the hospital to get CAR T therapy with axicabtagene ciloleucel. On day 4 after receiving his CAR T cells, he develops a fever up to 102 and a decrease in the blood pressure to 92/52. What are we going to do next? What are we going to do next? All right. Over half the group is getting blood cultures and x-ray and starting some empiric cefepime and vancomycin and IV fluids. I completely agree. I'm also very concerned, of course, about CRS, and we're going to want to give tocilizumab. But again, more common things being common, we got to at least start the empiric therapy while we're getting all that set up. So let's see what happens with John. He's getting some fluids. He's getting empiric broad spectrum antibiotics like you guys ordered. His blood pressure is not responding to 2 liters of IV fluids, and he's still in the systolic 80s, and his lactate's elevated at 4. Now what do we do? Excellent, excellent, excellent. Tocilizumab, anti-IL-6, 8 mg per kg. So that's what we're going to do. This patient has clearly declared himself as a grade 3 cytokine release syndrome. Again, that includes fever and hypotension refractory to fluids. So he's going to get TOCI. Probably give him some more fluids, but he's on his way to requiring pressors and going to the ICU. But TOCI is absolutely the next step here to try and reverse this process. So summary of everything we talked about a lot. We know that these immune checkpoint inhibitors, PD-1, PD-L1, CTLA-4, Keytruda, Opdivo, tislelizumab, they all can have adverse events, and these are very different than the traditional chemotherapy. As we mentioned, they can present in any organ system. Again, my old adage is anything that can have the suffix itis appended to it can be involved in these related events: dermatitis, hepatitis, colitis, pneumonitis, etc. And it requires recognition of the agent received and high index of suspicion to ensure early and appropriate therapy. So hopefully you can see what the patient got, or the patient knows what they got, or you have a good relationship with the oncologist. You could pick up the phone and find out what they've got. But usually these occur within months of starting the therapy. It can actually happen, anytime though. It's quite variable, early or late. And we did see the excellent NCCN guidelines to help guide us in our assessment and management as it pertains to specific organ involvement. We saw the thyroid and the colitis example. And then ADCs, or antibody drug conjugates. They are a form of chemotherapy, and their toxicities are dependent on the drug that is linked to them. I like that it says form of chemotherapy. Some people will say, oh, it's not chemotherapy. It is. It's chemotherapy attached to an antibody. So yes, you may have some diminished side effect profile, but nevertheless, you still do have toxicity, particularly dependent on the drug, the payload attached to the antibody, as we talked about with the ILD/pneumonitis for Enhertu or trastuzumab deruxtecan. And then cellular therapies, namely CAR-T, chimeric antigen receptor therapy, as well as BiTEs, bispecific T-cell engagers. They can cause CRS and ICANS. So I want to reiterate that BiTEs, a lot of times people just think CAR-T and CRS, but BiTEs, same thing. They can cause CRS and ICANS just like CAR-T. And clinical pearls, ask cancer patients what therapies they're receiving and look them up. Absolutely. I don't think you have to have all this stuff memorized, especially the details of the ADCs and all that. If they're receiving immune checkpoint inhibitors, consider getting a CT chest if they're short of breath. Yeah, definitely have a low threshold for concern there. Same thing with the ADCs. Do not ignore transaminitis with elevation of AST or LT. And as we talked about, any itis, any kind of itis, IRAEs can involve any organ system. Fluids, close lab monitoring are critical. Fluids and close lab monitoring are critical for prevention and management of TLS. We all know this. And we didn't talk about this in detail, but good antimicrobial stewardship implies that not every single patient with neutropenic fever needs vancomycin empirically. Of course, different scenarios would be if they have an obvious gram-positive source, i.e. some kind of severe skin infection, etc. Just use your clinical judgment. And then when in doubt, call the oncologist on call or the treating oncologist. Yes, friendly oncologist is always there to provide the clinical information that may be missing, or anything else you need to know regarding the patient's therapy and what management would be recommended. But yes, knowing the patient's malignancy, therapy, and date of last treatment are crucial things to be aware of when determining the appropriate workup and management of these patients. And I think that is all we have. We have the, do I go to the post-test polling question? Yeah. So we're going to go through these questions now. Sam is a 65-year-old man presented with fever, 38.3, ANC 150, multinational. Yeah, this is from the beginning. Medical history, gastric cancer. He's currently on trastuzumab deruxtecan. GFR is 80. What would be your initial empiric treatment for this patient? Yeah, I agree. Cefepime would be the way to go, and it looks like more people got that correct this time. I think the big things are this patient is a little bit higher risk for neutropenic fever. His MAS score is low, puts him a little bit higher risk. So yeah, I think cefepime would be the better empiric choice in this setting. Next, Tara, the 60-year-old woman, got same drug, trastuzumab deruxtecan, comes to ER, fatigue, short of breath. She has grade 4 pneumonitis. What's the most appropriate management for this patient? Excellent, excellent. That's a big quorum there, 93%. Promptly initiating corticosteroid treatment for at least 14 days, gradual taper over the next month. But yeah, this is a grade 4 pneumonitis, clear radiographic findings with hypoxia, and no more trastuzumab deruxtecan for her. And then which of the following medications should be considered for prophylaxis for high-risk patients that could potentially experience tumor lysis syndrome? High-risk patients with a high uric acid level, what would we give? All right. So we have 40% on rasburicase. I think we would end up giving rasburicase for a high-risk patient if their uric acid was high. Now, again, if I saw a patient, a uric acid was normal around 3 or 4, then I'd probably just go with the allopurinol. They're all going to get allopurinol regardless, though. And yeah, pegloticase and febuxostat don't really play a role in this scenario. Febuxostat is typically used if they have an absolute contraindication to allopurinol, but there's some cardiac issues with regards to that. So I think that's all of the questions. And now we're at the question and answer session. So I appreciate your attention, everybody. It was really a pleasure talking to you about this stuff. It's interesting and I think very relevant to what you guys are doing in the hospital, taking care of patients. So thank you.
Great, thank you. I think let's see if we can maybe go through just a few questions. I know we have the fireside chat coming up. Are there any questions from anybody in the audience? To our C integrity folks, I don't see any questions.
I see one.
One. Okay. How do patients that develop ICANS do with steroid treatment? Do they have a full neurological recovery?
Yeah, so I think it really depends on how severe the ICANS is. I think the majority of folks do have full neurologic recovery, unless they have, something devastating like a stroke or something like that. The majority of them, they put them on steroids, they recover, but it's going to really be contingent upon how severe it is. And also, if it's with concurrent CRS, it's also going to be another risk factor for this being a more prolonged issue. But I think the majority of folks, at least the ones that I've seen, they end up having a full neurologic recovery. But, as we talked about earlier, ICANS can persist longer than CRS typically. So I've seen a lot of folks that have required pretty prolonged tapers of steroids. And I think it's pretty safe to say that a lot of them, by the time they're out of the hospital and not under your care, it's very likely they're not going to be completely recovered yet. And they're most likely going to be still on a long steroid course.
Great. How do patients that develop ICANS, we went through that. Would you give immunotherapy to a patient with Hashimoto's?
That is a really good question. I would probably pick up the phone and call my local endocrinologist.
Endocrinologist or rheumatologist?
I mean, I still think I'm going to call my endocrinologist. I mean, I think most folks are going to be getting taken care of by endocrinologists there, but that's a tough one. I don't think off the top of my head, I think that one's a little bit unique because it's not so much systemic. The concern is, would that put them at higher risk for having other immune-related adverse events like colitis, pneumonitis, et cetera? That's not one I think of as much when I think of like lupus and really severe RF. But yeah, I haven't had the Hashimoto's thing come up. I would have pause. That's a very good question.
How about the role of vancomycin on neutropenic fever?
I think it's institution dependent. I think here at my hospital, we've been shying away from giving it to everybody up front unless they have more of a clear indication for needing gram-positive coverage. But I think that's relatively new. I think when I was still a hospitalist several years ago, we were still giving vanc to everybody, but I've been seeing a little more stewardship with regards to vancomycin.
Yeah, it seems to be honing in on if you've got a line in place or something.
Exactly. Yeah. I mean, if you're really concerned about a central access issue and them having an infection with Metaport or something like that, yeah, they're going to
Let's take this one step further. Would you remove the line in every neutropenic fever?
No.
You remove all lines. When do you remove lines in neutropenic fever?
I think if they have clear gram-positive bacteremia, or if they have clear clinical evidence of infection of the line, but we're not removing the lines in every single person with neutropenic fever.
What happens if they have gram-negative bacteremia or and sepsis? You keep the line in?
I think in that situation, I'm going to defer to the ID doctors, but I don't think it's an absolute indication. But again, I'm not an ID guy.
Sure. What would be the best cancer treatment for a patient with colitis or Crohn's to avoid further problems with the gut?
Those patients are not going to get immune therapy.
There you go. So traditional chemotherapy.
Yeah, those folks are not going to get it.
Yeah.
And that's why I took a little pause with the Hashimoto's, because that's just not one I think of as much. But colitis, ulcerative colitis, Crohn's, those, especially people that have a very severe prolonged course that have required immunosuppression, for a long time. I mean, you're just not going to do it.
Right.
Because the concern is not just, I mentioned, it's not just the risk of having the adverse events, but it's the risk of exacerbating the underlying autoimmune issue. Okay. And, I don't want to mess around with exacerbating colitis or Crohn's. If I'm just exacerbating Hashimoto's, I don't know. But anyway, that just my knee-jerk reaction there.
So you honed in. I'm going to ask two quick questions before we go to the fireside chat. One is, you really stressed the points as I was listening about tocilizumab. When to use it, when not to use it. I think it's worth like really re-emphasizing it one more time.
Yeah. So tocilizumab, IL-6 inhibitor, you're using it for CRS, and I think you're going to have a low threshold. I mean, if you look at the guidelines we were looking at, they were saying that you were thinking about it if they had grade one meaning just a fever in the absence of hypotension. It's and you can consider it. Most folks would not go straight to tocilizumab if they have only a fever. So I do agree with that guideline. It's when they start to develop hypotension. And, you know, those questions we were looking at, I was talking about giving fluids, getting cultures, giving empiric antibiotics. You'd be giving tocilizumab while all that's happening as well, if they're developing at least grade 2 CRS. Again, fever with hypotension. Okay. Low threshold, because it's a low risk, big reward type thing. There's not a whole heck of a lot of toxicity with tocilizumab. Some people say, oh, is there theoretically a risk that the tocilizumab is going to compromise the efficacy and the cancer-fighting ability of the CAR T cells? And we don't have great data on that. So I can tell you, just on my experience managing these CAR T cell patients in the hospital, nobody taking care of these patients is shy about giving the tocilizumab.
Great. You function as a hospitalist and now as an oncologist. Are you seeing, are the treatment of this, do you see hospitalists doing these things independently of a phone call to the oncologist, or is it still, even though the hospitalist may be writing orders, is it a shared conversation on all of these cases? Or
So
how does oncology feel about the hospitals just managing? You know, a lot of when we are managing cardiology patients, nephrology patients, we're managing them. We're not calling on a lot of the if we feel comfortable managing heart failure, we're managing it without necessarily calling cardiology on every management issue. What do you think in this zone of oncology? Should it be the same way, or because oncology feels a little more sensitive about these?
That's a really good question. So I think the first distinction would be the CAR T versus the immunotherapy thing, because CAR T, I mean, that's still going to be under the purview of the oncologist. And yes, at our institution, we're in the process of having the hospitalists be involved in those patients, because right now we're primary on those patients. And I think if there is a change where the hospitalists are involved, it's still going to be us working together. Now, the separate thing would be if someone comes in and is having side effects from their immunotherapy or their antibody drug conjugate. Absolutely, I think that most likely you guys could manage, that on your own as far as, doing the appropriate workup, giving the steroids, et cetera. But I would still think the oncologist is going to want the phone call, because if a patient's having symptoms bad enough from the drug that we're prescribing, they have to go to the hospital, we need to know about it. And 9 times out of 10, we're probably going to know about it before they even get admitted. A lot of times we're sending them in from our clinic. But yeah, I agree with you. To some extent, it's similar to cardiology. You can manage these things, but I don't see a scenario where we're completely absent from the management while they're in the hospital.
Yeah. I also think what's going to happen is as things continue to evolve, many of the hospitalists that are practicing out there have not actually trained with these drugs.
Exactly.
So there is, whereas with heart failure, there's, they trained with those.
Precedent, yeah.
So that's going to, it's not going to be, it's going to take a while for there to be full independency, if you like.
And I don't think full independence is necessary, but
sure.
All oncologists are different. I know the structure is really different at different institutions. I mean, the way we are as our group, I mean, we're directly attached to the hospital, and most of us are pretty hands-on. I would not, if I had any patient that was in the hospital with pneumonitis from an immunotherapy of mine, I'd be rounding on them every day, and consulting and interacting with the hospitalists every day. Absolutely.
Yep. Well,